And we're live. Hi, John, and very exciting today for both of us as this is our first podcast for MedInsights Unleashed.
Yeah, I'm excited too, Zahra. I think this has been our dream. We've always talked about doing something that's spectacular for patients and HCP. So I think we've got a really great time ahead of us.
And even better is we have a longtime friend and colleague of ours with us in the recording studio, Professor Arndt Vogel. Thank you for being with us today. And Professor Vogel is going to walk us through some of the key data that's been presented within the adjuvant setting of liver cancer. So, Professor Vogel, I'm going to turn it over to you just to briefly introduce yourself to our listeners.
Yeah, first of all, thank you very much for inviting me. And I'm, of course, very honored to be the number one, I
Yeah.
would say, at least on your podcast. So, and it's really great. And I'm really looking forward to see how your podcast develops over time or evolves over time. My name, as you said, is Arndt Vogel. I'm by training a hepatologist. I worked for many years in Hanover, Germany, and I just recently moved to Toronto, Canada. And I have here a joint appointment at Toronto General Hospital and Princess Margaret Cancer Center. My focus is liver cancer, both from a clinical and also research point of view. That's it. That's me.
Liver cancer is the fourth largest disease that we have globally. And over 866,000 patients are diagnosed with liver cancer. Importantly, 780,000 die of liver cancer a year. That mortality morbidity rate is really high.
When you look at these data, it's really devastating, right? First of all, a very common tumor. Of course, the prevalence is higher in Asian countries than it's maybe here in North America or Europe, but still, I mean, the number of patients is still very high. And as you pointed out, unfortunately, most patients eventually die from this disease. If you look at the numbers, I mean, you get the impression that we have not made any progress in recent years, which I think is not true. We have really made a lot of progress, and specifically for those patients with more advanced disease. But still, the rate of patients that can be cured is still very low. And this is, I think, mainly reflected in the numbers you just mentioned. And I think what we need to always keep in mind that the majority of our patients have two diseases, the underlying liver disease, which by itself also contributes to the high mortality, of course, and also the liver tumor, the liver cancer, which by itself has a very aggressive tumor, right? And it did not respond or does not respond very well to chemotherapy. So it's really difficult to treat. But eventually, I think we have now made progress because we can apply targeted therapies, even if we cannot select our patients for specific therapies. And we have seen that the immunotherapies have an impact in this disease. So, and we do have a lot of local therapies. So I think we do have a lot of treatment options for these patients. We can definitely improve survival. And when you look at the survival data in the different stages, I mean, they're really improving over time in all stages. But curing patients, this is still the obstacle which we have not yet reached.
And thank you for sharing and highlighting those key components. Our main topic right now is to talk about some of the data that's just entered within that curative stage setting. Surgical resection and local ablation are considered curative. But for those patients that receive surgical resection or ablation, there's still a high chance of recurrence post surgery. So I was hoping that you could briefly walk us through the recent data from IMbrave 050 study that was presented last year in 2023, just so that the listeners are aware, and maybe we can further explore the components within the study and how this could impact the overall treatment, because it is curative. It's within a curative setting.
So first of all, not all patients, unfortunately, can get surgery, which is again related to what we have discussed before, that these patients also have a second disease, and the chronic liver disease frequently comes along with liver cirrhosis, which basically prevents these potential curative treatment approaches. So I think we already have a selection of patients that can get surgery at all. And then outcome is definitely reflected not only by the underlying liver function, but also by tumor characteristics, size, number of lesions, which drive the risk of recurrence. And we know from all these data that have been published so far that unfortunately, when we do liver resection or ablation, we can achieve our zero setting or situation, but the risk of recurrence is very high. And eventually, most patients develop recurrence, right? So the question was from the beginning, can we combine local and systemic therapies to increase the cure rate? And I mentioned this because when we discuss about the IMbrave studies, we need to ask ourselves whether we really have achieved that. But the idea is combining different treatment modalities should increase cure rate. I think this is at least my understanding for neoadjuvant or adjuvant treatment strategies. And this has not really worked out when we combine resection with, for example, one of the oldest TKI we use, sorafenib. So we have a study which was unfortunately negative. So adding sorafenib after resection did not really improve outcome. We have tried to combine these TKIs also with other treatments like TACE, and you may come back to this later on, which also failed. It was a long way to combine local and systemic therapies, but now, as you have mentioned, we do have a positive trial, the MREV 050, and with that, I think because it is the first trial, it is important, and we can discuss now whether it's practice changing or not. Just to briefly summarize the data, I mean, the primary endpoint was recurrence-free survival. Around 680 patients were included. They were treated either with only resection or they received in the adjuvant setting atezolizumab. The hazard ratio for the primary endpoint was 0.7 at the first interim analysis, and with that, it's a positive study. Recurrence-free survival was significantly improved. At the time of the first interim analysis, the overall survival data were very immature, even more than expected. So only 7% of the patients have reached this endpoint. And with that, we cannot know whether this treatment also improves overall survival. So we have to wait for more update. I think in the end, we state for now, and we need to go a little bit more in detail. IMbrave 050 is the first positive study and delays recurrence-free survival.
Thank you for covering that. Now, in terms of a couple of things I wanted to highlight for our listeners, if you could help us define recurrence-free survival, just for our listeners out there that don't quite understand what it may mean.
Recurrence-free survival refers to the time to recurrence or death after resection. This is an early readout. It was only an interim analysis. Still, it was positive at this point at time. Therefore, this study is and will remain a positive study. But I think here it's very important to discuss a little bit in more detail. What does it mean, and and to do that? And I'm not sure whether you will be sharing the Kaplan-Meier curves. What we are seeing is that the curves are separating very early, and then we do see a difference in recurrence-free survival between the control and experimental arm. But because it's so early, we do not yet have the median has not yet been reached, so we cannot say by which amount of month the adjuvant treatment increased recurrence-free survival. We just have the hazard ratio, which is obviously also very important. And there's a risk reduction of 30%, which sounds meaningful. But we also need to highlight that even with this limited update and follow-up time, that the curves are coming together at the end. And this is something that at least concerns me, because when the curves are coming together, it means that the rate of patients that have been cured has not been increased. Of course, that may change over time. Yes. So with a longer follow-up, most of us hope that the curves will separate better, and that when we look at the end of the curve, that we do see a difference. Yeah, this is what we usually expect from immunotherapies, that the benefit is specifically seen at the tail of the curve. And this is exactly that what we would also hope for here in this trial. If not, we would really need to ask ourselves whether this treatment is really clinically meaningful, even if it's a statistically positive study.
And from a safety standpoint, in your opinion, were there any new safety signals that were seen, especially within this curative setting?
Yeah, of course. I mean, this is something that is very important. And specifically, when we are talking about what I have just said, that at the moment, I do not see that more patients have been cured, right? I mean, we can't say that. Again, it's very early. Only a few overall survival events has been collected so far, which is good because it means patients are still alive.
Yeah.
But it prevents us to conclude that we really have a positive impact on survival. Again, we can hope for that, but at the moment, when we look at the Kaplan-Meier curve, we do not see that. And then I think it's even more important to understand, is there an impact on survival? And there is an impact. And actually, the experimental arm observed more death in the early phase, indicating that this treatment is related not only with the morbidity, but also mortality. Yeah, so it means that some death that have occurred in this trial needs to be assigned to the treatment. And of course, that is a concern. I mean, of course, there are side effects. I think there are no unexpected side effects. It's what we would have expected from the drugs that have been employed in this study. And I think atezolizumab and bevacizumab are well-known drug. Bevacizumab we know for many, many years. Atezolizumab is a little bit more the new kid on the block. But again, this is also available for quite a time. And I think we do know and understand the side effect profile of both drugs, which are related to the mechanism of action, so the immune related side effects with atezolizumab, but also the anti-angiogenic side effects for bevacizumab, which include hypertension, for example, proteinuria. So I think this is what we observed in the trial. So I think the overall side effect profile is in line with what we would expect, but we also have to state that some death occurred in both arms, and we have to assume that some of the death in the experimental arm related to the treatment. Hopefully, there will not follow more. But with this observation, it's even more important that we do see a survival benefit, at least in my view.
Question is really from a patient perspective, because I know that there's going to be longer follow-up. So what does longer follow-up mean? Does that mean another 2 years or 3 years? How do you describe this data if they're sitting in front of you? Because obviously they're not going to understand what a hazard ratio is.
I think this is a very important question, and I do have an answer. But maybe first, one point also to mention. I mean, we have the recurrence-free survival, we have the overall survival data, we have the safety profile. We also have quality of life, right? And the quality of life data that have been published indicate that there's not really a detrimental effect on quality of life with the treatment, which when you look at the side effect profile, you would also not expect, if at all. And this has been discussed when the data have been presented. Maybe that patient that received the treatment recovered a little bit less well, if you may say that, when you look at the overall quality of life scores. I mean, the patient in the control arm at the end did a little bit better compared to those in the experimental arm. But I think there's no meaningful negative impact, which is good, right? I mean, it's also important for decision making. But there are also a lot of points we don't know yet, right? And the one question, of course, is, if we do not improve survival, so what is the point of doing this treatment? And before I address this point, another point I would like to mention is, what is the impact on subsequent treatment? So if we have treated and started with atezolizumab in the adjuvant setting, if we get recurrent like 6 months later, would we use atezolizumab again? What is the impact of the first adjuvant treatment on subsequent treatment? I mean, we don't know. So I think we need to get more data. Yeah,
When you say more data, do you mean additional clinical trials?
more data from this trial, right? And what John just said, I mean, how long does it take? It will most likely take another 3-4 years until we have the overall major, important, meaningful overall survival data. So probably we need another couple of years, considering the delay already we are observing in the events. probably a couple of years to understand really the impact on overall survival. But then we also up to the investigators to provide more data, right? To do these post hoc analyses, to understand what is the impact. Anti-drug antibodies, for example, they do not play a role at the moment in clinical practice, but we know that they may occur specifically with atezolizumab. And what is the impact of these ADAs that are maybe induced in the adjuvant setting? What is the impact in the palliative setting? We don't know. Maybe it's nothing, but we have to think about it at least and consider it, right? Coming back to your question, how should I explain it to the patient? Yeah, usually I try to explain it as it is, right? And we know that some patients are cured after treatment, whatever we do. We know that some patients get recurrent, whatever we do. And there are some patients where we may change it from not cured to cured. I mean, this is the aim of adjuvant treatment, right? And how often can we achieve that? The best data we probably have in colon cancer, right? Depending on stage. We know that in up to 5, 10, maybe 25, maybe 30% of patients, we can make a difference depending on stage. How should I explain that to patients in HCC with IMbrave, with the immature IMbrave 050 data? I cannot, right? I mean, I cannot say that a single patient more will be cured. And the only thing I can say, we can delay recurrence. This is what the data show, and this statistically significant benefit. But I cannot tell you whether this will increase the cure rate. Obviously, I will not explain it in this way to a patient, but this is my dilemma, right? How should I really explain the data of IMbrave 050? Another point to say, at the moment, it's not yet approved, right? I think in the US, you can already use it. And then I think it depends on you, how you want to sell it, right? But in most other countries in Europe and for me here in Canada, I mean, we cannot use it anyway. So I don't really need to explain it. Yeah. And we need to wait for approval. And I think we will only get approval with some more mature data. So maybe at some point it's good that it's not available for all of us. I mean, another point is always myself. So what would I do if it would be me? And based on the data that have been published already, so would I do it? I don't know.
It's a tough one because what are your other options? You have a patient with high recurrence and you have other trials that have failed. You have this trial that's been the first that has statistically been shown to be positive. We're waiting for longer term survival.
I think it's a very tough decision, but I truly believe that we need to have more mature data, that we really need to better understand what is the real impact, and just delaying recurrence for a couple of months. Also, when we think about resources, right? Being now in Canada and with all the limited resources we have here available and the knowledge which treatments are offered or not offered, right? Or in other, also many European countries in which basically not all drugs in the palliative setting are at all available, despite having positive phase 3 data. Yeah, so I think it really needs to be seen in a global context. Yeah, and I'm honestly not sure whether we really need to jump forward to recommendations without having also like an approval by the regulatory agencies. Yeah, and I'm not really convinced that we will get it with these data.
You bring up a good point too, that in Brave 150, which is the metastatic trial, it's commonly used. And your comment about subsequent therapy, if this moves in, be very challenging.
At least something we need to keep in mind. Maybe there is no detrimental effect, right? But we have seen in colon cancer, for example, a Japanese trial showing that recurrence-free survival was improved with adjuvant treatment after resection of liver metastases. I mean, it's a different context, I admit that, but still, it also revealed that this had an effect on the biology of the tumor. So the recurrence pattern differed, and actually overall survival post-recurrence was shorter. And with that, there was no overall survival benefit. I think we really need to have more major data to understand what it impact. And even if we do not cure more patients, if we can improve median overall survival with the adjuvant setting treatment, I mean, I would be more than happy to use it. No question about that. As long as the Kaplan-Meier curves for overall survival are running completely together. And I cannot even state that we are improving median overall survival with the treatment. It's really hard to recommend this treatment.
Can you visually say what a Kaplan-Meier curve is and why we use Kaplan-Meier curves in oncology?
I mean, this is not really fun to explain a couple of
No,
curves, right? I mean,
it makes
uh,
it's not.
It's not a fun curve, but it's a good curve if they're positive.
positive thing, right? But it tells us in the end, it gives us a graphic impression to understand how long is the survival of patients after a specific treatment has been started, right? And if the curves are separating, means we do see a survival benefit, and that is a good thing. If the curves are completely overlapping, that tells us, I mean, there may be an effect, but it does not translate in an overall survival benefit.
That's great. Thank you. I just want to be able to ask another question, and I know you may have answered this, but for that patient, if they listen to our podcast and, they have a family member or they themselves, are going through this type of recurrence, given the challenges that we've just highlighted, lack of approval in various countries for the combination of bevacizumab, how would you best advise a patient in order to help them kind of deal with or move through their current status of their liver cancer if they're in this recurrence setting? What would be your advice for them?
And the main question is, what can we do today, right? Not having more data. Yeah. And I think if we are living in a perfect world, and like the US maybe, where everything is available, right? And
Yes.
some of my colleagues can already use atezolizumab as of today, right? I'm not against this treatment. I don't want to make a wrong impression here. Of course, every benefit we have for our patient is important, right? And I do understand from a patient perspective that it might be important to have the recurrence like after 1 year or after 2 years. Of course, it is important. But I think that we have two questions. One is, should we approve a treatment, and should we offer it, and should it be paid for all patients, which really needs to be decided on by the regulatory agencies with the advice of the clinical experts, of course, and we need to make this decision at some point. Yeah. And then of course we do have the patient perspective, and when we need to discuss this today, I mean, I think we need to also involve our patients, right? And explain how it is that if it's available, we can offer that. And then it's also up to the patient to decide whether he or she wants to get this kind of treatment. Yeah. And I think it's the same situation in adjuvant colon cancer, for example, stage 2, we can or may not do adjuvant treatment, right? And then, I mean, you have to explain it to the patients, and some patients that we think about in like a survival benefit of 5 to 10%. Some patients say, yes, that's it. I take it. I will do everything. Yeah. And some patients, what, 5 to 10%? Never, ever. I will not do that. Right. So, I mean, it's really also important to implement the patient perspective. And if you say it's a benefit of 5%, the word for some patient, it means nothing to other patients. Yeah. So I think it's something where we really need to make the decision together. And if it would be available for me today, I probably would recommend it to patients that I would consider as high risk patients, and discuss it whether we should do it or not.
Okay.
Do you think patients should be educated on what an MDT is, a multidisciplinary team? This is very much a disease where you do need a multidisciplinary team.
I think that's definitely important. And I think we should not, I mean, what I just said, I think we should include the patient in our decision making. But of course, we should not leave it up to the patient alone to make the decision. Yeah. So I think every physician who's treating these patients, you need to make up your mind up front whether you want to offer the treatment or not. And then you can decide whether with the patient whether you proceed or not. Right. So and best you do this in a multidisciplinary team where you basically decide together whether you consider a patient as a high risk patient and whether you would recommend adjuvant treatment or not. So I think it's good to have multiple people involved in this decision. And when the team comes up with a decision, yes, we think it's a high-risk patients, we would really recommend adjuvant treatment. I think this is also something that should be communicated to the patient.
And I think we could even talk about the MDT team on another episode because that's another big discussion because of the variability that exists, not just within Canada, but I know even across the world. But we're going to save that for another episode.
We had another subject that was going to be discussed today, another trial, which was in the intermediate setting of the disease called Emerald-1. And unfortunately, listeners, we did not get to discuss that today, but we'd love to have Professor Vogel come back and discuss this trial with us and what it means or challenges associated with it in current practice. Our time is drawing to a near end. So with that, Zahra?
I just wanted to say thank you, John. It's been, again, very exciting. And Professor Vogel, thank you for your time. Thank you for reviewing the key highlights of the IMbrave 050 data, some of the challenges that still occur. And, for the listeners, I hope that they have found this beneficial as well. And as what John said, we're putting on the spot, Professor Vogel, for you to return again on our podcast, on the MedInsights Unleashed podcast for discussion around the Emerald-1 data within the intermediate stage patient population. So thank you again for your time.
Big hug for being our first
Yes.
specialist oncologist, hepatologist. Thank you from the MedInsights Unleashed team.
Thank you very much.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.